Stand by. This is your 1-minute warning. Stand by.
Good afternoon, ladies and gentlemen. My name is Nirav Shah, and I am the Director of the State of Maine Center for Disease Control and Prevention. I'm joining everyone today to provide an update on the COVID-19 situation across the state. We begin today's update, unfortunately, on a somber note. The Maine CDC is reporting the passing of the 65th individual with coronavirus. This gentleman was a man in his 70s from Cumberland County. He leaves behind friends, family members, and a community. And we, all of us at the state, offer our deepest condolences to those individuals during this time of grief. Overall, Maine CDC is now reporting 1,462 total cases of coronavirus across the state, representing an increase of 36 cases since yesterday. Of those cases, 1,328 are laboratory confirmed and 134 are probable cases. 200 individuals have been hospitalized, and currently 37 individuals are in the hospital right now. Of those 37, 17 are in intensive care and 9 are on ventilators. As I mentioned a moment ago, there have unfortunately been 65 individuals across the state who have passed away with coronavirus, and 872 individuals who have recovered. Since beginning our work around coronavirus, Maine CDC epidemiologists have now fielded close to 6,500 calls for consultation from healthcare providers across the state. In addition, our colleagues over at 211 have fielded over 14,400 calls from Maine people across the state, asking and answering questions about the coronavirus situation statewide. Of the 1,462 cases that we have, 315 are among healthcare workers. I'd like to provide a quick update on some of the outbreaks that Maine CDC is actively working on right now, starting with 3 new outbreaks. The first is at the Maple House, where there are a total of 3 cases. The second is at the Residential Community Support Services Group, where there are a total of 4 cases. And the third is at the Granite Bay Care Facility in Brunswick, where there are a total of 3 cases. I'd also like next to provide an update on some of the ongoing outbreaks that Maine CDC has been involved with. At the Augusta Center for Health and Rehabilitation, there have been 48 residents, 28 staff, and unfortunately 7 individuals who have passed away. At the Edgewood Rehabilitation Facility, there have been 13 residents and 6 staff, and unfortunately 1 individual who has passed away. At the Hope House in Bangor, there have been 18 residents and 4 staff members for a total of 22 individuals. At the Maine Veterans Home in Scarborough, 32 residents, 23 staff, and sadly 13 individuals who have passed away. At the Springbrook Center, which we talked about last week, there are now a total of 17 residents and 8 staff members for a total of 25 cases. No individuals there have passed away. At the Tall Pines facility in Waldo County, there have been a total of 32 residents and 11 staff, and sadly 13 individuals there who have passed away. At the Cedars facility, 11 residents, 6 staff members, and 1 individual who has passed away with coronavirus. And although it's not a long-term care facility, the Tyson Foods poultry processing plant in Portland continues to have and record 51 total cases of workers affiliated with that plant. Maine CDC staff continue to be engaged in each and every one of these outbreaks, working on contact tracing and providing advice to each of these facilities on the best way to keep staff members, residents, and those who may be coming in and out of the facility as safe as possible during these challenging times. I'd like to provide next some updates on our public health emergency preparedness activity front. And the first set of updates regards our work around mental health and spiritual care for individuals who are on the front lines of responding to COVID-19. Just in the past few days, there have been a total now of 21 separate psychological first aid training sessions, wherein 531 individuals have been trained just in the past month. These are individuals who have now been trained and equipped to provide counseling and spiritual care services for any individual who may have been affected by COVID-19, be they a family member, a patient, or in this case, a healthcare worker themselves. We've got further training scheduled as well over the next several days, over the next several weeks, to continue training individuals so that they too can go out into their communities, whether they be in person or these days, more likely, over video conferencing or over the phone, to provide that vital psychological assistance during these difficult times. All too often in outbreaks, in any emergency situation, we focus on the body, but these are important reminders that we must also focus on the mind as well. Another activity on our public health emergency preparedness front has been our efforts working in partnership with the National Guard to get as many healthcare workers in Maine fit tested. Just today, this morning, our teams were providing fit testing and PPE training for almost 100 staff members across healthcare facilities in Maine today alone. 12 at the Reddington Memorial Home and 86 at a facility in Skowhegan. Since beginning this statewide effort to conduct as much fit testing as possible, Maine CDC, working with our partners at the National Guard, have fit tested 375 healthcare workers and still have at least 700 healthcare workers who are waiting in the dock to try to get themselves fit tested as well. I'd like to take a second once again to thank our colleagues at the National Guard for undertaking this set of training exercises across the state. The more healthcare workers who become fit tested, the more healthcare workers who can take advantage of these life-saving N95 masks. We thank the Guard for their partnership in this effort. Maine CDC has also continued our efforts to push out PPE to healthcare workers and frontline staff members across the state. Just today alone, there are nearly 40 orders for PPE that will be going out. About 60% of those orders are going to congregate care settings, such as long-term care facilities, and about 30% of those orders are going to local fire, rescue, and EMS facilities across the state. That is to say, Maine CDC is continuing our effort to push out PPE to your neighbors, to healthcare workers in your communities who are using it to keep themselves safe so they can continue providing healthcare to everybody in their community. Since beginning our efforts to push out PPE, Maine CDC has now completed about 1,550 orders for PPE across the state. And again, we continue doing so as requests continue to come in. In terms of the vital statistics on hand, right now across the state there are 307 total ICU beds, 157 of which are available. There are 310 conventional ventilators, 224 of which are available, and there remain available 413 alternative ventilators. I'd like to take a second to recognize an effort that has been going on and that has been really, truly remarkable across the state. We've talked a lot about PPE and the shortage statewide as well as nationally for a lot of the vital life-saving PPE. Well, over the past few days, over the past few weeks, a group of high school students called the Delta Prime Robotics Group have taken it upon themselves to start 3D printing PPE across the state, specifically face shields. I've got one of those face shields here. Now, I recognize it's a little difficult to show a transparent object on TV, but this is a tough piece of plastic with a hook that healthcare workers wear that, based on the data that we've got, keeps them safe from being infected from PPE, especially if they're wearing it in concert with the surgical mask. This team, the Delta Prime Robotics Group, realized several weeks ago, since many of them were out of school, at a time when they would normally be otherwise competing in robotics competitions, they decided to try to take their time and their knowledge of robotics and 3D printing and do something to help out healthcare workers across the state. After they started getting requests for face shields, they did some quick crowdfunding and bulk purchased the materials that they would need in order to continue with this 3D printing effort in a more sustained manner. Now, they tell us that the response they got to this crowdfunding request was nothing short of amazing. In fact, it went above and beyond, both in terms of monetary donations as well as donations for materials. As a result of that, this group, the Delta Prime Robotics Group, is now manufacturing a bit over 100 face shields per day. And they're continuing to increase their own supply to try to print as many of these face shields as possible. To date, the Delta Prime Robotics Group, these high school students who would otherwise be competing but have now decided to join the effort to help out, they have manufactured and donated 1,200 of these face shields to Maine CDC. Now, for those of you who know folks in the Delta Prime Robotics Group, maybe some of you folks are watching right now, I want you to know that each and every one of these face shields is being used. We bring them in, we put them in our inventory, and they get treated like any other face shield that we might have, which is to say if a hospital, a nursing home, or a fire and rescue or EMS agency makes a request for face shields, this might be what they're getting. And so I want each and every one of you guys to know that the work that you've been undertaking is being used right here today by healthcare workers across the state. Now, they're not the only group that's doing this. For example, the Open Bench Project in Portland has been undertaking a similar effort, and I similarly thank them. But I ask everyone to go take a look at the Delta Prime Robotics website. They've got a Facebook page, or you can just go to deltaprimerobotics.com. Take a look at what they're doing. This is a group of students in Maine who have decided to join the effort to try to provide healthcare workers with PPE. And I've got to tell you, it's nothing short of inspiring. And on behalf of the entire emergency preparedness team, as well as all the healthcare workers across the state, we very much thank you. I'd like to end by just taking stock of where things are right now. These continue to be strange times. The warmer weather tells us it's a new season, and the word on the street is that it's a new month. we're all dealing with change in different ways. In my own household, Netflix appears to be playing a cruel joke by recommending that we watch either Contagion, Outbreak, or Pandemic. Either it knows us too well or it doesn't know my family at all. And if a deadly virus weren't enough reason to stay inside right now, we now have murder hornets to deter us, but thankfully not in Maine. Many of our streets and our towns have been empty because of something unseen, this coronavirus. Now, of course, you've probably seen images of what it looks like under a microscope. The odd spheres that are studded with spikes that the virus uses to infect our cells. But the virus on its own is not visible to the human eye. We can't see it drifting through the air, stopping on surfaces, traveling from one person to another. Indeed, if we could, it would be much easier to stop the virus from spreading. Invisible things, like viruses, are unnerving precisely because we can't see them. But among the many effects that this virus has had on society, the one that I wanted to think about, and I have been thinking about, is the way that the coronavirus has prompted other previously unseen parts of our society to now be seen. For example, in the way that we now recognize and appreciate those who have been working throughout the entire coronavirus situation. Now, I have, on numerous occasions, given props to those out there who are the most often seen. These are the very well-deserving folks on the healthcare front lines, such as EMTs, nurses, pharmacists, home care aides, hospice workers, law enforcement, and physicians. But there's another group out there, another group of workers who are less seen and simultaneously far more appreciated now than they were before. People who, because of the nature of their job, may not have been able to work from home during this time. People who have been and continue to be on the front lines even before there was a front line. Like the community members who stock the shelves of our grocery stores. Like the letter carriers who deliver the increasing number of packages that we're all getting. Like the retail store clerks who are there when we need to find just the right part to fix our broken water heater. Like the person who works at a poultry processing plant, making sure that each of us has food for our families. Like the convenience store clerk who sells me a pint of Ben & Jerry's at the 7-Eleven down the street from where I live. These may be folks that we look at every day, but not necessarily have seen every day. But just like the coronavirus itself, though we may not have seen it, we now know each and every one of these workers' importance and value to all of us. In fact, it's because in the face of the coronavirus that we now see them. And we now see that the work they do is and has been vital this entire time. But how do we acknowledge them? For me personally, it goes well beyond just acknowledging that they're doing a job. I think it entails acknowledging the fact that the work they do has always put them on the front lines. And so I'd like to take a moment to more than just acknowledge them, but express our gratitude for these workers and acknowledge the individual humanity that each and every one of them has and their contributions to our overall effort. In times of crisis, gratitude and shared humanity are arguably the only things that matters. Indeed, during the darkest times of any crisis, it may be the only things that we have. So I'd like to thank each and every one of these employees and workers across the state for continuing to support all of us and help keep us connected. So with that, I'd like to turn things over to our colleagues in the media, and we will turn first to Brian Sullivan over from WABI.
Thank you, Dr. Shaw. Hope you had a great weekend. It was nice to hear your final thoughts. I had a couple of Diet Cokes in your honor this weekend, so I hope you got to enjoy a couple too.
Yes, indeed.
I got a couple of questions for you. With the 12 counties that have had the restrictions lifted, if there is a surge in cases, what recommendations would you make in those cases?
Sure. So Brian asks that with the 12 counties where there have been steps toward a gradual reopening, if there's a surge in cases, what recommendations might be made? So Brian, first, just as a note, the reopening is indeed gradual. Retail right now, restaurants to follow, and both with restrictions in order to keep folks safe. But we continue to keep tabs on the data. So for example, if we were to detect, just hypothetically speaking, something like a spike in cases, or potentially a spike that generated community transmission, we would have to reevaluate whether we would want to continue down that path. None of that is new. It was set forth in the documents that the governor has discussed. She herself has mentioned that. But I think what's important to note is that this is not a one-way ratchet. We're continuing our analysis of the data because we want to make sure that if a secondary spike were to occur, that we're able to spot it and able to take policy steps accordingly. Now, what those policy steps may look like, Brian, is very much a function of what we see and where we see it and the populations in which it occurs.
Okay, thank you. Of the 4 counties that have had community transmission, I was wondering, does that designation ever go away, or once it's happened, it always will be listed as having community transmission? Like, does a period of time pass where that designation might be listed?
So Brian asks about whether community transmission itself is a designation that could go away. It's conceivable that it could, Brian, but it seems unlikely. What we see once there's community transmission is that cases continue to propagate. That's what's appeared in the data. Now, there could be a situation where if coronavirus behaves, say, like the seasonal flu or norovirus, a gastrointestinal disease, it could drop off. But based on what we've seen so far, it's unlikely to happen, but we're keeping our eyes open for it. I would like to turn next over to Kevin Miller over at the Press Herald.
Hey, thanks, Dr. Shaw, for doing this as always. One, just a clarifying question, then kind of a more detailed question. So the new outbreaks that you've mentioned, can you just tell us where the locations are of all those places? I think one was Maple House, and then as you mentioned, the third one was in Brunswick, but then there was a second in there that I didn't get a town for.
Yep. So I'm going to triple check that with Robert, Kevin. I believe the Residential Community Support Services, I believe that's in Sanford, but we'll triple check that. And the Maple House in Spurwink, again, we'll get you the exact location. It's part of a series of other homes that are in the area. And so we're trying to figure out actually if it's a singular discrete outbreak or part of an existing outbreak affiliated with some other centers in the area. So that that information is really just a couple hours old. Again, in the interest of transparency, we wanted to put it out there, and we'll get you at least the locations. But as a note for everyone, if it appears that from an epidemiological perspective, say the Maple House is actually part of another outbreak because they share a number of staff and residents, it might just be lumped in with an existing one. So I hear your question, Kevin. We'll get you the answer.
Okay, great. And just another kind of general question, obviously taking a look at the active cases that we see every day, we have seen them going up since last week. We've had several outbreaks, but, I think we had a jump of 14 today, I think. Mm-hmm. Is that concerning to you? And how much does that play into your decisions about kind of what your recommendations to Governor Mills on the reopening plan?
Yep. So Kevin asks about the increase in active cases, or cases generally, to be candid with you, and how does that affect how we think about any type of phased reopening? Well, a couple of observations, Kevin. The first is that the decisions and discussion around reopening are not premised on any one metric. It remains a global set of metrics that include not just the case counts, but also things like hospitalization, hospital preparedness, and background levels of flu. The other thing that I think is important is the geographic distribution of those cases as well. That information is on our website, where we do break it down by county. And thus far, we haven't seen a significant spike in non-urban parts of the state. If we do see that, sort of consistent with Brian's question, that is something that would pause us and can prompt a reevaluation. But again, all of that, again, is in the context of expanded amounts of testing that were done last week at a couple of facilities, namely Tyson and Springbrook. So for all of that is a wind-up, Kevin, to say that given where we are in the outbreak right now, day-to-day variations are interesting, but what we base our policy decision-making on is really much more of a 7-day or even a 14-day moving average. That really gives us a better sense of what's transpired, not just in the past 24 hours, but really over the 7-day period. Early on, when we first started doing these briefings, we would start a briefing at 11 a.m., and by the time I'd walk out, we'd have an additional case that I would be coming back in the room to report on. Given where we are in the outbreak now, it's more of a moving average. And so that's really kind of how we look at day-to-day variations. We try to take that 7-day look.
And are you still okay with where we are as far as looking at the 7-day and the 14-day average? Are you surprised, or are you concerned at all?
No,
with where we're headed?
it's a good question, Kevin. We're going to probably by midweek this week release an updated data set in terms of where things stand with a lot of the metrics we've been talking about, hoping to have that out again midweek. But based on the numbers that I looked at over the weekend, this metric that I go back to a lot, which is the positivity rate, seems to be holding steady, if not trending in the right direction, which again means that the number of cases that we will see invariably might continue to go up, but so long as they are a function and being driven by increased testing, that's a sign that shows that our testing is hitting the right marks. So that's kind of how I'm thinking about it right now.
Great. Thank you very much.
You bet, Kevin. I'd like to turn next to Kara DeRose over at the Maine Beacon.
Hi, thank you. My question is around our increased testing capacity. So with this increased testing capacity, I was wondering if the Maine CDC had begun thinking about universal testing in congregate facilities like factories and group homes prior to outbreaks, not after outbreaks. And I was wondering what is being done to help to test in the home support specialists who go into the homes of people with disabilities and are in direct contact with them.
So Kara asks about whether what is the thinking around universal testing in various congregate settings before an outbreak hits. And we've had really extensive discussions around that, including with a very large and well-respected organization here in the state to think about how we might approach that. There are a number of questions that are out there when we start thinking about that, questions that we've talked about at these meetings. For example, how often should we retest individuals? Should we test everyone in the facility, or, for example, just start with the staff? And then, of course, the most difficult question of all, how should we think about positives? Before we go down that pathway, we have to make sure we've thought through the policy implications of someone testing positive. Can a staff member be adequately moved in such a fashion so as not to pose a risk to others? Can patients be cohorted so that they too can avoid infecting others? We want to do this, but it's one of those situations where we've got to make sure we've got a plan in place before we go down that route. Maine was I think, the first, if not one of the first states to break rank with the U.S. CDC and put congregate testing, like in nursing homes, in our top tier. Now we become one of the first states, if not the first state, to get rid of all of our tiers altogether once we're fully online with our new testing capacity. So we've been ahead of the pack at every step of the way when it comes to universal testing. Now, when we think about rolling out universal testing in all congregate settings, we're not averse to it. We've just got to think through all of the implications before we go down that pathway, not midway through. That's the discussion that we're having right now, and that's the science that we're looking at. I'm happy to talk more about that, but it all comes down to the positive predictive value. And for anyone who's watching right now, take a second after this is over to look at the positive predictive value, and you'll see why this can be concerning from a policy perspective and why we have to think that through before we go down that route. Going over to News Center, it appears that Colonel Kerrigan is off today, and so we will turn to Pat Callahan from News Center.
Yes, Dr. Shaw, good afternoon. Appreciate you taking the question. As antibody testing increases, some governments and businesses, not just in this country but in other countries, have been talking about so-called immunity passes for people who have already had COVID-19 as a way to know who has had it, and that might make a safer reopening of the economy. Do you have any thoughts about the feasibility or usefulness of this kind of designation?
Sure. So Pat asks about immunity passports that have been talked about in other countries, and indeed even in some places in the United States, as a way to provide a bit more of a security blanket around reopening. And Pat, the entire immunity passport idea is necessarily predicated on there being a good, useful, reliable antibody test. And right now, according to the US FDA, as well as according to the American Public Health Laboratory Association, the science just isn't there to support the policy. There are good tests that are on the market, although there are a lot of tests that are on the market that actually last week FDA said, you have 10 days, manufacturers, to prove that your test is good, and if you can't do it, we're going to take your test off the market. The fact that FDA even had to make that statement tells us that there are a lot of tests out there of dubious quality. So before we can think about immunity passports, as the term is used, we have to make sure that the scientific footing on which that idea is based is solid. And right now, it's not there. Now, it might be. And it's possible that in the coming days, weeks, months, the science around immunity and antibody testing will get there. The tests could be better, and our understanding of what a positive test really means could really be there. But as of right now, my view is that we need to approach it with caution. I got to say, Pat, this is probably the #1 question that I get asked, and the science is evolving really, really quickly on it. So check back in with me because it's changing really quickly.
Thank you, Dr. Shaw.
I'm going to turn next over to Megan at WMTW.
Thank you, Dr. Shaw. My question may be similar to Kevin's question, but when we had spoken about outbreaks at congregate care facilities a few weeks ago in relation to, what percentage of the rising cases or additional new cases they were, you were relatively certain that you gave me the balloon analogy, that you were sort of tying them off, as in these weren't cases that were really out in the public or cases of community transmission per se, for the large part. Can you speak to that again, and do you still feel that's true?
Sure. So Megan asks about, of all the cases that we've seen lately, what fraction of them are accounted for by congregate settings as opposed to community transmission, or, Megan, I'm going to throw on top of that household transmission as well, between close contacts in a household. So here's kind of where things stand right now. If you take a look at all congregate settings across the state, so this includes long-term care, assisted living, the Tyson Foods plant, things of that nature. If you take a look at all of them, what we have are 389 total cases between residents and staff. On a daily basis, it really does change. So 2 weeks ago, Megan, when I first deployed that analogy, we were seeing a lot of our daily cases being accounted for by outbreaks in facilities. And our goal at that time was as I noted, to think about outbreaks like a balloon animal. Those long balloons that balloon artists twist off. And as they twist them off, I'm going to let Dr. Thibodeau go on the balloon animal front for a bit. As they twist off the balloon animals, they essentially lock off that outbreak from trying to prevent it from spreading across the entire system. And what we've seen is that there has been some amount of stasis in the number of new cases that have been reported at these facilities. The numbers have been largely steady. And that's a testament to the owners and operators and the employees at those facilities. It shows that with prompt, decisive action, outbreaks of COVID-19, even though they may start, need not turn into infernos. However, and so as a result of that, Megan, for example, just in the past couple of days, the number of new cases that are accounted for by outbreaks in long-term care and congregate settings is down to single digits. The other cases that we're getting on a daily basis are the result of community transmission or, more commonly, household transmission. A spouse who may be confirmed who then passes it on to other family members. But the reason I go through all that, Megan, I know that was a lot, but that could change really quickly. There will invariably be additional outbreaks in congregate care settings. Unfortunately, that is a risk. Maine CDC and Maine DHHS have been really proactive in getting out there to those settings, pushing PPE to them ahead of time, surveying them about their needs, providing refreshers on hospital-associated infection reduction practices, all of those things. But unfortunately, outbreaks in these facilities nationally tend to be a risk. So what we're doing now is making sure that we can talk about things like testing in those facilities without worrying about the resource constraints. So this could change, and the complexion of that balloon animal will continue to change. Right now, it's a bit more in stasis mode, but again, that could change very quickly. Sorry, that was a pretty long answer, Megan, but I wanted to give you all the numbers there. I'm going to turn to Kate Koff over at the Ellsworth American.
Thanks, Dr. Shaw. So we have been getting a number of questions about Remdesseviere, which I know that we've talked about in the past. And, you know, I think today we've seen reports that the U.S. is going to get, I think it's, you know, a little over 600,000 vials over the next 6 weeks or so. And can you talk a little bit about your understanding of how that's going to be distributed and, you know, whether Maine expects to get any and whether any doses that were already on hand in the state have been turned over to an allocating authority?
Great. So Kate asks about a treatment, a potential treatment for a COVID-19 infection, a drug called Remdesseviere. This, too, has been a question that's come up quite a bit. We at the Maine CDC have been in touch with our colleagues at the United States Department of Health and Human Services over the weekend about the potential for distribution of Remdesseviere to the state of Maine. We are working to make sure that any confirmation that we get includes a date, place, and time of that delivery. As soon as we do get confirmation that the Remdesseviere has been delivered, we'll make sure to update everybody. But Kate, your bigger question is around the distribution of Remdesseviere. This drug is a drug that's used in patients who can be critically ill, and thus it requires hospitals that already have the critical care backdrop in order to be able to administer it. We're thinking about how to distribute the drug or any supplies that we might receive, and we'll probably do so in keeping with the percentages of overall critically ill patients that have been cared for by hospitals in Maine. So if a particular hospital system has cared for 50% of all the critically ill COVID-19 patients, that's a pretty good indication that they should receive approximately that much Remdesseviere. However, our expectation in making this distribution whenever we receive it, and we haven't received a final delivery date, if at all yet, but when we do, our expectation will be that hospital systems across the state share the drug with other hospitals that may need it on a quick basis. load balancing in this fashion is the only way to distribute this drug with that prime principle of health equity in mind. So there's much more to come on Remdesseviere, and once we get further information and a confirmed delivery time from the federal government, we'll be able to chat with everybody about how we're approaching it. I would like to turn next over to Steve Missler at Maine Public.
Thank you, Dr. Shaw. I have two questions. I'm going to just let you answer the first one, and then I'm going to have a second one about the positivity rate that you've been talking about. I guess I'm wondering if you could provide a bit of a risk assessment associated with the governor's plan to begin loosening restrictions. I know you've addressed this in part today with answering some questions, but it seemed as though early on that case counts and other factors were playing a role in decisions to actually implement those restrictions early on. But as we continue to see double-digit case increases, we're moving to reopen or restart the economy. And that's before the state has actually implemented its new testing regime, which I think you said last week may not be in place until later this week. I guess how much of a risk is the state taking by moving ahead now? I mean, what do you tell the governor when she asks you that kind of a question, I'm assuming that she does?
Sure. So Steve's first question is about the potential risks entailed with moving ahead with reopening in rural counties. And Steve, I can only speak, of course, on the public health side of things. Commissioner Johnson has talked about the economic side of things, of course. But on the public health side, it's not so much the cases, but their distribution, partly on a geographic basis. Where are we seeing new cases on a county-by-county level? But also, what type of facilities are we seeing cases in? And if we go back to this balloon analogy, if many of the cases that we see happen to be, for example, in long-term care facilities, if we can cordon those cases off and prevent them from generating community transmission on a more widespread basis, that gives us a bit more security. But I think the bottom line here, though, Steve, is that the question, I think, is any type of movement here toward any kind of reopening may involve some degree of risk. We can't quantify what that risk is. It's very difficult to know whether by opening up this particular store in one particular county, there's an appreciable increase in risk. The coronavirus, again, is only 5 months old. And so the data that we might need in order to make that assessment are challenging. But what we can say is that in certain parts of the state where there has been a very low background rate of disease, and coupled with the possibility that providers in those areas who may have been self-restraining themselves against testing out of fear for resources would not need to do that anymore because of the expanded testing increases that will be online later this week. I feel like, the way that I've thought about it is that we've got an appropriate degree of safety that's built into the system based on the fact that individuals may already be interacting. They would hopefully be wearing face coverings, which we continue to recommend. And then if there were to be some type of outbreak, we now have the testing infrastructure in place such that providers don't need to worry about tiers and prioritization schemes. So, that's kind of how I've been thinking about it. It's important, I think, to recognize that the complexion of the outbreak across the state of Maine has been different in rural areas versus more densely populated areas.
Thank you for that. And then the second question I had is about the positivity rate. I just happened upon one biostatistician making asserting that the positive rate that people have been focusing on was a bit of a stand-in when there wasn't a lot of testing to be had. So in the absence of widespread testing, they were looking at positivity rates to get a sense of whether or not there was enough testing happening at all, or just to get how bad an outbreak might be. Is that a fair assessment, do you think, or is there some value in that metric at this point?
I'm familiar with that line of inquiry or concern that's been raised. So Steve's question is, what is the enduring value of looking at the positivity rate which is to say the percentage of all tests that are done that come back positive. Maine's rate has been, thankfully, low, and that's one of those things where the lower you are, the better you are, as compared to other states and other cities. And what that tells us, at least at first blush, is that the net that we've been casting is a pretty broad one. So, Steve, I think the question really is, under what circumstances and for what types of tests is a positivity rate something that we should look at versus other types of tests where it may not be useful? And for some types of tests, we know it's not a useful metric. For example, tests like the test that looks at hemoglobin, that follows people for diabetes, right? That's not a test where we look at what percentage of the overall tests are above a certain threshold, because we already know the test is pretty widespread and easy to do. But for other tests that are a little bit more challenging, where we do have concerns around access, including, for example, influenza, we do look at the positivity rate even to this day. The main reason we do so, specifically in infectious diseases, is that unlike for chronic diseases, cholesterol, diabetes, there's not as much of a problem about the size of the total iceberg. We generally have a good sense of the number of people with diabetes. The same thing with heart disease. But with things like the flu, with things like other infectious diseases, including, in this case, COVID-19, when we're still trying to characterize the size of the outbreak, the positivity rate still has value even as testing availability expands. Now, there are other metrics that we may also build into that. For example, like the antibody testing rate, the seropositivity rate. We may also start looking at those, but the baseline positivity rate, given where we are in this outbreak, only 5 months in, still, I think in the opinion of myself and my counterparts in the other 49 states, is still something we're looking at. I am going to turn next, you bet, going to turn next to Mike Fern over at the Maine Edge.
Thank you, Dr. Shaw. My first question concerns the other background respiratory illnesses you just mentioned. Have we actually seen a quicker decline in flu cases than normal this time of year due to the mitigation?
Yes. And it's rare I can give a one-word answer, so yes. However, I can't help myself, so what I would ask everyone to do is to Google Maine CDC influenza report. Virtually every week, for even in the midst of COVID-19, we have still been churning out our weekly report on influenza rates. And Mike, you will see right when you pull that report up, in the very first box on the upper rows, the left hand and the right hand, you will see that as a result of social distancing and other measures that have been undertaken, physical distancing, not just COVID-19, but influenza overall has dropped precipitously across the state of Maine.
Good. And my second is, do you have any suspicion that COVID-19 or something similar may have been in Maine as early as November, December?
Yeah, that's a question that actually just came up on a briefing I was doing just about an hour ago. The question is whether COVID-19 may have been in Maine or before the first case was diagnosed. It's difficult to say, Mike. What I can say is that it's possible that there were cases a little bit before the first official diagnosed case, but the supposition that's out there is that there may have been a high number of cases in the fall of last year. In the state of Maine, there doesn't seem to be a suggestion that that was the case. We don't have a high number of reports, for example, of individuals with respiratory illnesses where all of the diagnostic tests were negative, which would be something that we would look back at to see if it might have been here earlier. Now, I am only confining those comments to just the state of Maine. It is theoretically possible that there could have been cases of COVID-19 in higher traffic cities such as the Pacific Northwest, the West Coast, in areas of that nature. But as to Maine, we don't have data to suggest that there was a spike of unknown respiratory illnesses late in the fall. You can't rule anything out. I want to be clear. These are scientific questions, and in science, it's impossible to prove a negative, as everyone's probably heard. So I can't prove that, but based on the data we've got, there doesn't appear as if there were high numbers of respiratory illnesses of unknown cause back in the fall.
Sure. Actually, just to follow up to that.
Yep.
So are there samples available that you can actually go back and test?
I don't know that hospitals would have maintained those samples. There are requirements to keep those if they are of special public health interest. But again, if there were samples and they all tested positive for influenza, adenovirus, RSV, one of the more commonly known viruses, I don't know that any hospital would have kept those. But that really would be something the hospitals would know based on what they've maintained.
Thank you.
You bet. I'm going to turn next to TJ Tremble over at ABC 7.
Good afternoon, Dr. Shaw. Thank you for taking my question. It talks about, you mentioned several times about a surge in cases and so forth, and that inevitably we'll see an increase in confirmed positive cases when the testing expands. Is there a number of new cases in your mind now that would qualify as a surge?
Yep. So TJ asks about a potential surge. Let me say a couple things about that, TJ. The first is, although there's a lot of concern for a secondary spike, I think it's important to remember that we're still in the midst of a primary spike. So we're really focused on where things stand right now, but we're also planning for what the future may hold. There may be a secondary spike. It may be larger than the first spike. It may be the same size, or it may entail several consistent small flare-ups. We just don't know yet enough about the transmission of this virus to know what any kind of subsequent spike may look like. Now, in terms of what we would define as a resurgence, we have defined that based on some mathematical parameters, but essentially it goes back to the moving average that I was chatting with Kevin Miller about. We really look not just so much at a day-to-day difference, because that can vary based, for example, last week on all the testing that was done at Tyson Foods, that day-to-day variation can be high. So we look at the moving average of the last 7 days over multiple 7-day periods to try to get a sense of whether we're going in an upward direction or a downward direction. And then we put certain mathematical parameters around that to determine when that would constitute a surge. All of that is really just a way to make sure that we're holding ourselves to what we believe is scientifically needed. But the fact is, based on more testing, as you note, we anticipate there being more positives. That's why that positivity rate that Steve Missler and I were chatting about, that's why to me it's important, because the positivity rate takes into account not just the more tests that we're doing, but the likelihood of finding more cases. If the positivity rate stays the same, even if we triple the amount of testing, that tells us one thing. But if the positivity rate goes way up, even as we triple more tests, we're finding a lot more cases for each test we do. That tells us a different epidemiological story. I'm going to turn next over to Caitlin Andrews at the BDN.
Thank you, Dr. Shaw. My question is on the 3 new outbreaks that were announced today. I know it might be kind of difficult to answer because we don't know too much about them. But do you know if those cases might be spread across multiple homes, or are they clustered maybe within the same group home? And how would you treat an outbreak that is just like centered in maybe 1 or 2 group homes versus like a bigger congregate care facility?
Sure. So Caitlin's question is about the 3 outbreaks I noted. I just wanted to make sure I provided the numbers. At Maple House, there were 3, residential community support services 4, Granite Bay Care 3 individuals affected. The way that we think about outbreaks, the essence of an outbreak, is not so much an uptick in cases, but it's an epidemiological link among those cases. So, for example, in the flu season, we have a lot of cases of flu, but that doesn't mean that there is one big outbreak happening. What defines an outbreak, the essence of it, is that epidemiological connection. So, Caitlin, if we determine that, for example, there are 2 residential facilities right next to each other, they're separate buildings, maybe they're a block apart. If we determine that the reason that they're both simultaneously having a lot of cases is because they happen to share a lot of the staff and a lot of the residents go back and forth, that's that epidemiological link that really is the essence of an outbreak. And rather than treating that as 2 separate outbreaks, we would treat it as one unified outbreak, and the interventions that we would suggest would apply as to both. That's really the analysis that's underway right now at each and every one of these facilities to try to get a better sense of what the epidemiological links are between these facilities and any other facilities in the immediate adjacent areas. Once we get a better sense of that, it may be that these outbreaks they may not appear on our list because they may be subsumed as part of another outbreak. Does that answer your question?
Partly, I think so. I guess I would kind of just ask again, like, how would you treat, so the idea is kind of like if there were two homes that were next to each other and there would be a link between them because those people visited, you would treat that differently versus if they saw outbreaks for unrelated reasons, right?
That is correct. That is correct. It all goes back to trying to figure out what that epidemiological link is within the residents of the home, i.e., how did the outbreak get introduced, and whether that same linkage applies as to other facilities in the immediate area. Was there a single employee who may have been I'm just making this up hypothetically, but hypothetically, was there a therapist who visited multiple homes that we can think about as part of an epidemiological link? And if the facilities have enough epi-links between themselves, we may constitute them as one singular outbreak as opposed to distinct outbreaks. A lot of that, candidly, is just the way that we categorize them. The interventions are what really matters. And the interventions are largely the same, regardless of what the introduction was, which is to say limit visitation, things of that nature. I'm going to turn now to Amy Brown over at WERU.
Thank you, Dr. Shah. I have two, I think, quick questions today. Maple House, you mentioned that's a spur-week facility. Those are typically group homes for kids. Do we know if this outbreak is actually at a children's home?
The answer is, I'm just trying to see if I can share that without revealing too much in the way of confidentiality. Amy, you know what? We're gonna double check to see if it's okay that I share that information. If I can, then Robert Long will be in touch with you. We do have that information, but again, out of respect for privacy, I want to make sure that it's acceptable to share it. So if we are able to share it, you will hear back from us, Amy.
Okay, thank you. And allergy season is upon us. Is there any information about whether having allergies makes you more susceptible to either contracting the virus or having a worse outcome if you do get sick?
So Amy's question is around the interplay between allergies and the possibility of COVID-19. Amy, I think there's a lot of research that's being done on that. And right now, it's probably too early to tell. We do know that individuals with allergies may be predisposed to other respiratory conditions like asthma, and those allergies can exacerbate asthma. But the extent to which allergies may predispose anybody for any respiratory viral illness, whether it's COVID-19 or something else, I think at least as it relates to COVID-19, there's more research that's being done to better characterize that.
Does that inflammatory response that comes with allergies complicate things if somebody does have COVID, or is that still under research as well?
Well, the inflammatory response that entails an allergic reaction from hay fever or pollen is not the same type of inflammatory response that drives much of the body's reaction after COVID-19. They are both inflammatory responses, that much is certainly the case, but the way in which they take hold in the body and manifest is quite different. So thankfully, this is a situation where there are degrees of different types of intensity of inflammatory response. And trust me, as an allergy sufferer, the reaction you get from hay fever can be rough, but thankfully it's not on the same scale as what you get from COVID-19. The last question today goes over to Brad Rogers at WGME.
Hey, thanks, Dr. Shaw. For the staff at long-term care facilities who tested positive, do you know where or how some of them became infected? And I have one other question.
So Brad asks about where staff at long-term care facilities may themselves have been infected. And Brad, based on what we've seen nationally, there's not a clear answer. But based on what we've seen nationally, the staff at facilities are likely to be exposed in the same way that any other member of that community may be. Perhaps it's because they live in a county with community transmission. Perhaps they've got a close contact, whether in their household or in their circle of friends who may have been exposed. So there's not a single way in which any staff member may have been exposed. But once an outbreak starts propagating, there is some evidence that staff members may themselves pick up COVID-19. That's one reason why we are so quick to try to get PPE to long-term care facilities as soon as we detect an uptick in cases.
Okay, and then SARS went away quickly. What is it going to take for COVID-19 to go away?
Well, so Brad asks about what it might take for COVID-19 to go away full stop. And Brad, you ask it in the context of SARS, which in many respects had epidemiological characteristics that were much, much different from COVID-19. Earlier in my career, I worked on SARS at a time when I was living in a different part of the world. And the key difference that made SARS go away more quickly was also because people took steps to protect themselves. But with SARS, the time at which someone was the most infectious, the time at which they could transmit it to people the most quickly, was after they started developing symptoms. Once you develop symptoms with SARS, everybody knew to stay inside. And so there wasn't a lot of transmission once folks got symptoms. Coronavirus, COVID-19, is different. The data suggests that people, as many of you have heard us talk about at these meetings, the data with COVID-19 suggests that people are the most infectious the day that they start developing symptoms, if not the day before that, which means that folks can still be out there transmitting the disease before they know they've got it. That makes it much more challenging from a control perspective as compared to SARS, where once people started feeling bad, they automatically just stayed inside because of how crummy they were feeling. But COVID-19 is different. So that poses different challenges in terms of how we're going to be able to get our head around it and really control it. It's entirely a function of different types of epidemiology, and it shows why when you're looking at disease outbreaks, even a day or two really makes a big difference. I'd like to close on the note earlier, which is, again, something that I've been thinking a lot about, in the ways in which an unseen virus has prompted me, at least, to see different parts of my world. And as we're all grappling with and contending with COVID-19 in different ways, for me, at least, it's really important that we acknowledge not just folks who have been on the healthcare front lines, but folks who have been on the front lines as workers even before there was a front line. They have been the ones keeping us connected, keeping us fed, keeping our households running, and allowing each and every one of us to continue, whether it's staying inside or going into the office. Those members of our society that have been previously unseen are now seen. And I hope that as we go forward and continue moving through the coronavirus phases, we don't let them slip back into being unseen. Thank you very much, everyone. Have a good afternoon. We'll talk tomorrow.